Can we request all to take seats, please? Whenever we start anything big, we always seek blessings of God, and therefore I would start with Ganesh Vandana. Vakrtund Mahakaya Surya Koti Samaprabha Nirvignam Kurme Dev Sarvkaryeshu Sarvada. हे लॉर्ड गणेश, आपकी ब्लेसिंग्स लेकर के हम ये मेदांता चेस्ट ट्रॉमा with the explanation of the concept of this service. Dr. Bilal.
Thank you, sir. Very warm good afternoon to everyone here. On behalf of the Institute of Chest Surgery and Lung Transplantation at Medanta, the Medicity Gurugram, and Medanta Hospital, Noida, I warmly instant tail leak, poor lung expansion, missed airway specialist input. So it is for continued care. So transferring back to the referring doctor to complete the loop of the care for chest trauma. So it is a regional chest trauma safety net where expertise is actually traveling faster than the patient. So the patient may take some time to come to the hospital, but it will take much faster for our advice to reach there, and that's the entire ethos of Medanta Chest Trauma Service. So I welcome you all to join hands with the Medanta Chest Trauma Service, because har ek jaan anmol hai. In trauma care, minutes saves lives, but collaboration saves future. I now invite Professor Arvind Kumar to take the proceeding further. Thank you very much for a patient listening.
The basis for thinking about developing such a service was analysis of a very small 114 patients that we treated here over the last 5 years that we have been here. And there was some very important message that came out from that study, and that is what led us to think of this study. So this, we moved here in December of 2020. So this data looks at our experience from 21 to 25, during which period we have 114 patients of chest trauma. As expected, majority of these patients were male, because that's how the distribution of people is on the roads. The, as expected, 45 to 65 group constituted majority, but the difference was that nearly half of the patients had a trauma severity score more than 15, which means that they were severely injured patients. We thought that road accidents will constitute the biggest or the only bulk of our disease, but we were surprised that road traffic accidents was 42%, and very surprisingly, falls from height. Somebody has some construction going on in the house, so he slips. Somebody is on the first floor, second floor, and by chance slips on the stairs. This constituted nearly 36%, which was a surprise to us. 42% road traffic accidents falls from height, and a very peculiar group, which I think is specific to our country only, is bull hits, which constituted about 8%. So bull on the road coming and hitting the person, and the the horn going directly into the chest, and all kinds of injuries happened. We also were of the opinion, as we learned from newspapers, that pedestrians are the most affected. But somehow, and I think this could be a referral bias, we had very few pedestrians, but two-wheeler riders constituted nearly 60% of our patients, which was surprising to us, and about 30% were those who were in the four-wheeler when the accident happened. Isolated chest trauma was about half, which is because, again, probably a referral bias, and about 45% patients had polytrauma. Now, this is important, that rib fracture constitutes nearly 2/3 of the injury. So this is a simple injury which can very well be managed by all doctors at the periphery, but a good number of these patients were also referred. They also had complications. They also had need to go to ICU because of wrong or delayed management. And in about 42%, more than 3 ribs. This I compared with my previous experience at AIMS and then at Gangaram, where usually 1 to 3 ribs used to be involved, but here majority of our patients had more than 4 or 5 ribs involved, and about 16% of patients had multiple bilateral rib fractures, which I think denotes high speed accidents which are happening on the various highways. So I think increase in the speed of the vehicles leading to more force at the time of trauma is responsible for increase in the severity of chest wall trauma, because chest wall tends to absorb the bulk of the trauma, and it's only when the chest wall is badly injured that this trauma goes inside. 40% patients had pneumothorax and hemothorax, and when it comes to management, a good number of them actually needed medical management only. When I say medical management, it means pain relief and taking care of their other needs. We did not even have to put chest tube. And this is the significant that this population actually does not need to come to us. This can very well be managed here. And that's exactly what we plan to do in this service, that those who can be managed at peripheral centers, will assist them in managing it there, and those who need to come to us should come to us. ICD insertion alone was in 1/4, but this is an important segment. Nearly 30% of the patients needed some kind of surgical intervention. And friends, this is the group which needs to come here because they need the kind of expertise which is only available here. We found out that as the duration since accident increases before they reach to us, there is a direct correlation with the length of stay. So if they came early, the length of stay was shorter, and those who came late, the length of stay was normal. Very stark difference we found between cases who arrived at our hospital directly after trauma versus those who got admitted elsewhere and were referred. Direct admissions were about 60% and nearly 40% were referrals. But when we looked at the injury severity score, the injury severity score was much higher in the referral group. The delay was, as expected, more in the referral group as compared to those who came directly. More importantly, when we looked at 4 important parameters, their need to go to ICU, their need to be on ventilator, their requirement of undergoing specialized chest surgery, and the duration of hospital stay. All these 4 parameters were higher in the referred group as compared to the group which had come to us directly. So referred patients are more likely to require ICU care, ventilatory support, surgical intervention, and stay longer. And this is what we thought, that this group which is reaching us is not the entire group. It is only the tip of the iceberg. There is a huge segment of the same type which is out there in the periphery, which is not reaching us. On the other hand, there is a group which does not need to reach us, which is reaching up, and we need to intervene and reverse this trend so that those who need our help reach us, and those who don't are managed at the, so it's a early, specialized and coordinated care for chest trauma. By getting in touch with people, we will try to do a triage at the level of referral hospital only. If we feel it can be managed there, we will assist our colleagues. So there are two components of this service. One is the clinical component and other is the educational component, where through physical programs, through CMEs and through a lot of online programs, we wish to upscale the knowledge as well as skills of people across the North India, where chest tube insertion and other things can be done, so that a lot of these things can be managed. There will be round the clock availability of thoracic surgical expertise, all aimed at shortening the time to definitive care in those who need to come there, aimed at improving the outcomes. So transfer criteria will be as per the latest, that is the major chest wall injury, multiple rib fractures or other major injuries. Those patients will be referred to us. So this is the basic ethos. This study was actually the stimulus for thinking that there is a very skewed kind of referral which is happening. Sometimes those who don't need to come to us are coming to us, and those who actually need to come to us are many times not reaching. And this is an effort to reach out to all, increase the knowledge and skills and decision making, be involved in the decision making, so that those who stand to benefit from our care come to us and come to us in a supervised way. Every month we have one or two cases which has been, without discussing with us, referred to us, and there are mishaps which happen on the way, severe injuries get aggravated, but this service will ensure that the referral happens in a hassle-free, supervised, safe manner, and when they reach, we are ready to receive them, and those who don't need to come to us actually don't come to us. So that's the concept of trauma service. Sir, if you allow 5 minutes, I'll just quickly finish this, or else you can. Okay. So next few slides, these are about 35 slides, but I'll be rushing through. Since this program is going YouTube live across all 6 Medanta locations, as well as going YouTube live into various medical institutions and to a lot of colleagues, and there will be a lot of residents also who are part of this program, we thought we'll just run through some essentials of chest trauma management, just as a initial curtain raiser of how we propose to do the educational part of this program. Chest trauma is a major public health problem responsible for significant morbidity and mortality. It accounts for 25% of deaths. Many of these deaths can be prevented, and this is important, and this is the reason for developing this service, if you can diagnose them early and treat them aggressively. These could be because of blunt chest trauma, which could be because of road traffic accidents, falls or crush injuries, or this could be penetrating trauma, which could be either stabs or firearm injury. Chest is surrounded by this bony structure, so this bony structure takes the brunt of the attack in most of these schema cases. So you can have isolated rib fractures, flail chest, sternal fracture, or various kinds of fractures. So we have sometimes this kind of picture where you see from top to bottom there is hardly any rib which is spared, and sometimes we have this grotesque picture present bilaterally. You can imagine what will happen to those patients when the trauma reaches inside. There could be pneumo, hemo, or combined thorax. There could be contusion or laceration to the lung. There could be all kinds of cardiac or aortic injury, esophageal injury, tracheobronchial injury, or injury to the diaphragm. All these can happen. This leads to hypoxia, hypercarbia, and acidosis, and that's how these people deteriorate. Now, this is an important slide which shows how the trauma leads to death. So there are some immediate on-site deaths where major injury is there and there is nothing that any system can do. Preventive methods like seats, belts, etc. are important. Then there is an early death which happens within hours, where level of care can make a difference, and we do wish to contribute to this part. But more important is this late death which occurs over the next few weeks because of missed injuries or injuries mismanaged, which is where our major intervention is going to be trying to reduce this third type of death. Management, pain relief is the most important part, and of course there are various other methods of managing it. I have put all these slides, but I'll be just showing the title only because I don't want to have it a regular chest management class, but just to give you an overall. When you have more than 2 or 3 ribs fractured, you have flail chest, which causes problem. Whenever we have these kind of patients with significant injury, always admit and then do the management. Oftentimes this question is asked, does every patient with rib fracture need fixation? Because all other bones when they are injured, they are fixed. So oftentimes patients ask this question, aap ribs ko kyun nahi fix kar rahe hain? So the answer is, ribs have a tendency to heal well. It's only when there is a respiratory failure, when there is a significant chest wall deformity or failure to wean from mechanical ventilation, or significantly displayed ribs found at thoracotomy, which is going into the lungs. So in these cases only we tend to fix the ribs, or if there is a flail segment which is causing ventilatory problem. The earlier you do it, the better it is. We have all kinds of plates and other things available. Just show you one example. So this was one patient where you can see multiple ribs were fractured. Now this patient would never ever be able to go off ventilator. So we took him to the theater and multiple titanium plates were put, and about 2 weeks later this patient did come off ventilator and he's still following up in the OPD, and this is how the chest X-ray looked. Similarly, there are patients with fracture to the sternum, which could be because of motor vehicle and various other injuries. So whenever there is an unstable fracture or there is a severe pain or respiratory difficulty, we always do a detailed analysis, bony injury analysis, and then, so this is one case where you can see because of the direct impact of the steering wheel, this part of the sternum broke and went inside. If you leave him alone like this, this is going to cause serious problem. So we took him to theater and straightened the bone and fixed it with a titanium plate, and you can see the 2 titanium plates, and this kind of intervention done early allows these patients to be discharged very quickly. Another patient where also you can see this plate has been put. This patient also had spine injury, so rods were put in the area also. So these are the bony part. Then you can have pneumothorax, you can have hemothorax, you can have parenchymal injury, you can have tracheobronchial injury, you can have diaphragmatic injury, you can have esophageal injury. There's so many organs which are there. Oftentimes people think that chest is just tuberculosis, but friends, it's much, much, much more than that. So these are all injuries which need specialized management. So what is the message? That chest trauma needs a specific treatment plan. It's not something which can be managed by any and everyone. Pain relief is a very, very important point and an important part. The good news is that if you do chest tube drainage, which unfortunately is not done, none of the district hospitals in any of the North Indian states put a chest tube, which is such a simple procedure. And that's one area where we wish to reach out to the governments and have Zoom classes for people from all district hospitals so that this facility is available now onwards in district hospital. But this kind of management is able to manage more than 85% of chest trauma, which can actually be managed in the periphery. Unfortunately, it doesn't happen today. What needs our care is only 15%, which also does not reach us. So this Medanta chest trauma service aims to address this, that those who can be managed at the periphery will be managed in a careful, supervised way, and those who need to come to us will be assisted to reach us and get the care. And I'll end by saying that pain relief forms a very important component of the overall care of these patients. With that, it's my proud privilege and an extreme honor to request Dr. Trehan to kindly come to the dais, press the button, inaugurate the service officially, and also bless us with his golden words. Sir. ये वाला डाउन वाला ये वाला प्रेस कर देना जी मैं कर एक सेकंड आप बोलेंगे जब ये वाला एक बार बता दीजिएगा बस।
So Arvind, you've done it again. That's great. No, this is a very, very important initiative that you and your team has taken, so my compliments for that. And we, in the past we have done many protocols, like the stroke protocol or the MI protocol, and also our tele-ICU program, which is actually centered more in Lucknow. The amount of difference it's made in saving lives is unquantifiable because of the fact that the intervention happened immediately. So what you have embarked on today, which is a brave campaign to start, where a cardiac or a chest surgeon will be available 24/7 to be able to advise them. And today technology has come to our rescue where you can do a video call, you can do a video connection on your phone, you can see real time what's going on. So the advice that you can give to people, and especially we are located in an area where the highways are just crisscrossing more and more. And a lot of our Haryanvi friends have the habit of driving on the wrong side of the road. And some of our Punjabi brothers who would like to drive their Rolls Royces at 200 miles an hour in the morning and kill a few people. So I think there is a lot of contribution that something like this can make, and it's a good initiative and a good commitment more than anything else that you're actually providing help to the people, not even thinking about the return to your team, but the effort will be immense. So my compliments, and thank you very much for bringing this kind of program to Medanta, and also the reach with which people will appreciate it, I think will be very rewarding and gratifying to you and your team and all the other team members that we have here. So thank you for giving me the opportunity to be with you on this important event, and good luck and march on. Thank you.
I now request, thank you very much, sir. I now request Dr. Harsh to come. We have our colleagues lined up from 4 geographical locations. They have some patients of chest trauma present there, and we made a small capsule where we requested them to just put the details of their patients on a slide, and we will be having a live consult with them. Dr. Harsh will take you through this part of the program.
If we can project the screen.
अच्छा शेयर स्क्रीन पे ये वाला स्क्रीन टू शेयर अब प्रेजेंटेशन का
प्रेजेंटेशन नहीं सर, प्रेजेंटेशन है, हमें जूम करना है सर, यही वाला।
विंडो खोल दो। अच्छा ओके,
यही बस।
इसी को शेयर करना
हाँ।
है, इसी शेयर करना है, तो फिर हमें वो चेंज करना पड़ेगा। रुको, शेयर ये वाला स्क्रीन
बस इसी से।
आपका वीडियो आना चाहिए ना।
एक मिनट खोल देता हूँ। नहीं रुक ये स्क्रीन शेयर करना।
Which can you want to?
यही बस ठीक है, आप यहीं रुक जाइए। किनको करना है डॉक्टर?
पहले अंकित, डॉक्टर।
हाय डॉक्टर अंकित।
Hello, Dr. Saab. How are you, doctor?
So, Dr. Ankit, if we can have a small introduction of yours and the case you want to share with us.
Sure. So, I'm Dr. Ankit Jhara, practicing in Central Delhi. I'm representing Adya 9 Multi-Speciality Hospital. I'm a medicine specialist. And
Hi, Dr. Ankit.
yeah, so should we?
Dr. Ankit, can you hear us?
Yes, sir, I can. Can you hear me, sir?
Dr. Ankit.
Yes, sir. Can you hear me? Can you hear me, sir? Hello, can you hear me? Dr. Harsh? Sir, I can't hear you.
Okay. Now you can hear us?
Yes, I can hear you. Can you hear me? Yes, sir.
Okay, thank you. So please, if you share this case.
Yes. So I'll just share the case, sir, and I'll be introducing myself. Is my slide visible?
If you can share your slides.
I'm already sharing it, sir. Is it visible?
Are you sharing your screen?
Yes, sir. I am sharing my screen. Can you see my screen? Can you see my screen? If you can give me a heads up, I'll start. Yours is muted, so I can't hear anything, sir.
इनका कौन सा
उनका है pneumothorax.
है ओके
अपना स्क्रीन शेयर कर रहे हैं ना एक्चुअली दो लोग एक साथ स्क्रीन शेयर नहीं कर पाएंगे ना नहीं इनके तो हटा दिया है
हमारा हटाया हुआ है
अब वही है ना म्यूट अब उनसे बोल लो पूछ लो कि आप देख पा रहे हो नहीं देख पा रहे हो म्यूट है ना सर म्यूट हटा दो
now you can see the slides
Should I share or are you sharing, sir?
if you can read it from here only
All right, not an issue. Yes, I can. So I'll be introducing myself first. I am Dr.
Sure, sir.
Ankit Vihara, medicine specialist. I'm practicing based out of Central Delhi. I'm representing Adya 9 Multi-Speciality Hospital. So today I'll be discussing a case with you all, and I would want your guidance with it. The history of the patient is 19-year-old male with the history of assault. He got hit by an iron rod, multiple assailants on the 3rd of February 2026 at around 9 p.m. The patient presented with left side chest pain and dyspnea, blunt trauma on the chest, and direct impact with the rod, and no other associated injuries. So the clinical findings. So the clinical findings were the general condition of the patient was pretty good. Vitals were 110 beats per minute. The respiratory rate was 26 per minute, and BP was noted as 110 by 78 mmHg. Saturation was 96 on room air, and the chest exams, what we saw and what we heard was the reduced chest expansion on the left side, decreased air entry, and hyperresonant percussion was noted. So if we can see and look at the X-ray that we got at that time. So my question to you, sir, is that it's a left-sided pneumothorax. Should I place an ICD and manage him here?
100% as it is a pneumothorax which is more than 30% of the chest area is in the left side. An intercostal drain immediately should be put in this patient.
All right. So, and how do I take care of the ICD and provide other supportive care to this, sir?
Sir, if you have a dedicated general surgeon there, he will be able to take care. Otherwise, we will be providing you with the material in a PDF format, which will show all the steps of ICD management to you, which will be available in next 15 minutes on your WhatsApp.
Sure, sir. And when should I refer this patient to you?
So basically, the referral purely depends upon the British Thoracic Surgical Guidelines. If after putting the chest tube, the lung expands in the next 12 hours, you can get a chest X-ray, see the expansion. If it is fully expanded, there is no air leak, we are not bothered. But if in 5 days, if it is not doesn't happen and the lung is still not expanded, then we have to refer the patient to a thoracic surgical friend.
Got it. So I'll be reaching out to you then. Sure, sir. Sure, sir. Thanks a lot. Thanks a lot for solving my queries. And good luck and congratulations. Thank you.
Dr. Pankaj, if you can hear me. Pankaj? Dr. Pankaj, can you hear me? Dr. Raj?
Sir, congratulations for your efforts, sir.
Dr. Pankaj?
Yes, sir. I'm hearing you, sir.
Oh, great, great. Dr. Pankaj,
Congratulations to you and to your team, sir.
please introduce yourself and what case you want to share with us.
Sir, myself, Dr. Pankaj, intensivist at Sapra Multispecialty Hospital, Hisar, sir. I'm presenting the case which came here on 4th of Feb with history of RTA, severe chest pain, marked breathlessness. The mechanism of injury was high energy blunt trauma to the left side of the chest.
Okay.
And at the time of presentation, patient was having pain discomfort, general condition was fair, pulse rate was 124, shallow rapid breathing of rate 28, sir. BP was 100 by 58. Room air pressure saturation was 91%. There was paradoxical left side chest wall movement with decreased air entry in basal region, sir. CT chest was done, which was suggestive of these multiple rib fractures, and it's on the screen, sir.
Sure. So do you have any questions regarding this case? I've seen the CT.
Yes, sir. There were left side multiple rib fracture 3 to 9 with flare segments, and mild hemothorax, lung contusions was there, left clavicle, later third first fracture. Should I manage him here or what to do, sir? The patient
Sir,
was in
it's a
severe pain.
Yeah, it's
and
basically
breathless.
multiple rib fractures with flail segments. With a hemothorax, the first thing you have done very well that you have put in the chest tube and drained
Yes,
the
sir.
hemothorax. But the point is, in the CT, the flail segment can be seen, and there the lower lobe on the left side is collapsed. So you have to provide excellent anesthesia to the patient, a bronchoscopy immediately to see what is obstructing in the lower lobe, and to fix the flail segment. If you have a thoracic surgical support at your center, you are most welcome to manage the patient there. But if you still feel that your CTVS surgeon is not equipped or you don't have access to the specialized ICU care, then definitely the patient should be shifted to a higher thoracic surgical center.
This department, but based on requirements, we will have shift to your centers.
So the pain management should be done by putting a thoracic epidural. You have to screen the
Yes.
spine. If spine is okay, epidural it's indicated in this case. And from there, the main part, as Dr. Arvind has told in his presentation also, that the main thing in a care of a chest trauma case is to do the best analgesia. So a thoracic epidural is indicated.
Center, sir.
Thank you. Thanks a lot, sir. Thank you. Dr. Raja Khan.
So I'm audible?
Yes, you are audible. So, yeah.
Good afternoon, everyone.
Yeah, they are introducing themselves. They are introducing themselves. So, Dr. Raja, you can introduce yourself and please show the slides.
Thank you, sir. Sir, myself, Dr. Raja Khan from Meerut. I'm working as a consultant chest physician, Santosh Multi-Specialty Hospital, Meerut.
Sure, sir. Your case?
Sir, my case, sir, patient detail, 52-year-old male, come with the background of previously healthy, non-smoker, no previous comorbid condition. The mechanism of injury is RTA. Patient Sir, trauma in 7 days. Some am audible?
Yeah, you are audible.
Sir, initially we put the ICD 28 number in fifth intercostal space mid axillary line. Initially we drain 700 ml of blood. Patient now hemodynamically stable throughout, and we manage conservatively in ICU. And after stable the patient, we shift the patient into ward. The current scenario, patient ICD, we put the patient current status oxygen requirement 2 to 3 liter per minute via nasal prone, SpO2 94 to 95% on oxygen, respiratory rate patient is 22 cycle per minute, chest patient persistent analgesia. On chest examination, air entry decrease in lower, right lower and middle zone, and ICD patent but minimal drainage for last 48 hours.
Okay, minimal drainage.
Yes, sir. Sir, chest X-ray shows persistent right lower zone opacity, elevated right hemodiaphragm, incomplete lung expansion. Sir, we repeat the CT scan after 7 days, shows incomplete expansion of a lung and hemo collection of blood.
Okay. Any questions for us? You want to?
Sir, further how we proceed the patient, and this is the indication of early VATS decortication or not, sir?
So, excellently managed case. An ICD was put on time, but it is a clotted hemothorax basically, and it has been 7 days now. A clotted hemothorax will definitely turn up into an empyema in few days. So, it would be better if we go in early, do a VATS procedure, clean it up, and the lung will get expanded. That should be the, if you have a thoracic surgical backup, a CTVS backup or a thoracic surgical backup at your center, you are most welcome to manage, and we are ready to assist you there. But if you don't have such facilities available, I'll advise you to refer the patient to a higher thoracic surgical center.
Okay, sir.
Thank you, Dr. Raja.
Thank you, sir. Thank you.
So, Dr. Anukul.
Hi, sir. Can you hear
Hi,
me?
Dr. Anukul, how are you?
Hi, fine. How are you? Congratulations on your new venture.
Thank you. Thanks a lot, sir. So, you had a case of a 32-year-old male. If you can tell us about the history.
Can you please share the slides?
Can you see the slides?
No.
Yeah. Now you can see them?
Yeah, now it is visible.
Thank you.
Yeah, hi. Myself, Dr. Anukul Jain. I am practicing as a pulmonologist in Agra, and I have a case to discuss. There is a 33-year-old male without any comorbidities, which was accidentally hit by a bull on 4th of February at 10 a.m. And he presented with penetrating wound to the right side of chest, and ICD was placed at a local hospital with the local wound care.
So this kind of injury we can expect only in India only. Dr. Arvind was just telling these bullhorn injuries, very peculiar to India.
Yeah. So the condition was, the condition of the patient was very poor. The pulse was 122. The BP was 98 by 62 mmHg, and the respiratory rate was 30 per minute. And the saturation was 86% on room air. So on examination, there was a penetrating chest wound of approximately 5 into 4 centimeter. And there is a CT that we can see. And there was reduced air entry on the right side, and ICD was placed in situ. The video of the CT you can see.
Okay. Okay. So I've seen the CT, sir. Any questions from your side?
Yeah, my question is there is a right-sided penetrating chest trauma with open pneumothorax, and there are multiple displaced fracture of the right 1 to 6 rib with the undisplaced right clavicle fracture. So the question is, should I manage him here, or what should I do? Or does the patient is required to be referred to you? And what will be the special care that should be taken while patient being referred to you?
Okay, sir, as it is an open wound, initially the case is managed very well. I can see an ICD being put there, and the wound care has been taken care of. But the problem with the open wounds are they need exploration and rest. I can see a very particular finding in your CT that there is a falling lung sign. So we have to do a very good bronchoscopy to see whether we have a tracheobronchial injury, very common in these cases. If you have a CT West backup there in Agra with you, or you have a thoracic surgeon friend who can come and assess these things, well and good, we are ready to assist him there. But if it is not present there, I'll like you to send the patient to a higher thoracic surgical center like Medanta. And during the shifting of the patient, if there is no cervical injury, the patient should be managed in a 45-degree right up in the position, and with oxygen support with a technician or a doctor accompanying the patient to Medanta hospital. So that would be the best scenario to shift this patient, and we will do a bronchoscopy, fix his wounds, fix his chest, and see whether there is a tracheobronchial injury or not.
Okay, so nice of you. Thank you. I will try to shift him as soon as possible.
Thanks a lot, sir, and all the best for the management of your case.
Thank you. Thank you.
Thank you. Thanks a lot, everyone, joining. So now we have come.
This was a sample of how this service will proceed. So these were cases at 4 different locations where people had got in touch. This is exactly how it will proceed. That we will have people contacting us, giving us details, and then we'll assist and if needed, transfer. So this is a live demo of how this Medanta chest trauma service will proceed. I request now Harsh to propose a vote of thanks.
So as we conclude today's formal proceedings, it's my distinct honor to propose the vote of thanks for this landmark event. It is the launch of बंद है इसको बंद कर दूं ना ना कुछ नहीं करना सर अब इसको बंद कर देते हैं ना ये So first and foremost, we would like to extend our gratitude to our chairman and managing director, Dr. Naresh Trehan, sir. It's his vision of taking the healthcare to the remotest possible point in the country that this kind of initiative we are taking. Thank you, sir, for this formal inauguration which you have done. A special thanks to Dr. Arvind Kumar, the chairman of thoracic surgery here, sir. Your leadership, your conceptualization of this thing that a 24/7 helpline can be managed, can be formed, and it will not be managed by some call center. It will be managed by a dedicated thoracic surgeon. I don't know how we will do it, but we'll definitely, because you have taught us to do this. I would like to thank the entire team of Institute of Chest Surgery, my fellow consultants, nurses, anesthesia department, Dr. Sangeeta and his team who provide us 24/7 support. Our ICU support by Dr. Yatin Mehta, Dr. Chitra, and support staff from our own department whose dedication has made this helpline a possibility. We are also grateful to all the dignitaries who are present here, medical people who have come from different parts of country to bless us. Sir, this kind of helpline is there to support you in managing these chest trauma conditions and difficult scenarios you have. We are just a phone call away. Our sincere thanks to the administrative team, Atul Barjatia, sir, and his whole marketing team, which have relentlessly worked for us throughout day and night. You guys are superb. So a live consult management by the IT team, which is excellent. This is very difficult, I must say, has been done by you. And in the end, I just want to say that it's a pan-Medanta initiative. It's not Medanta Gurugram initiative. It's Medanta Gurugram, Medanta Noida, Lucknow, Patna, Ranchi, and Indore, which have taken this initiative to help all the chest trauma patients across India. So in my closing statement, now this helpline is live, and I know that this would be a beacon of support to the thoracic trauma patients across. Thank you for all the support, and I'd like you to join us for the high tea. My thanks to all the press people present here and continuous coverage of this. Thanks a lot.